So from today onwards, you're gonna start seeing me in the videos. My name is Vishal Kumar. I'm the founder of this channel. And aren't you excited to finally see me? I know you are. So we're going to go through renal failure today. I am covering a series of topics in this series called the Think Like a Medical Registrar series. This is targeted at medical registrars across the country in the UK and the world, and also anyone preparing for MRCP or PACES. Okay, so if you fit into any of these categories, welcome to my channel. If this is the first time you're seeing my channel, and I hope that you benefit from my videos. Let's get started. In this video, first of all, the scenario which we're going to cover, followed by you, doctor, are going to give me your plan, okay? So your differentials and what you want to do with the case, with the patient who is your patient. Then we're going to proceed to some key considerations about the scenario, and then we're going to review the scenario and think about why we came to the conclusions that we have. Finally, we're going to visit the bite-sized bundle which I have created for you so that you can benefit from it for PACES itself, but also for your life, because it'll help you just retain everything much better, okay? So stay with me until the end. You're gonna learn loads, guys. If you want to make the most from this video, then if you see this bell icon, then make sure you pause the video and follow the instruction, okay? Let's get started. The scenario. We have Rick, who is a 76-year-old retired journalist who has been admitted with generalized symptoms of lethargy and feeling unwell. Fevers and night sweats. Okay, so some red flag symptoms here going on. Fevers and night sweats in an elderly man. This is not looking very good, okay? His past medical history includes type 2 diabetes, osteoarthritis, recurrent sinusitis over the last 4 months, and appendicectomy. Okay, so a few mixed things in the past medical history. He takes metformin, gliclazide, and paracetamol, nothing else, okay, no other medication. This is important because if he was taking non-steroidal anti-inflammatories because he's got osteoarthritis, this changes the scenario completely, okay? If he is in renal failure and he takes non-steroidal anti-inflammatories, this is because of these medications, most likely, okay? So you would just stop them and see how he responds. But he's not taking anything else, no other over-the-counter medications, okay? So let's see, what's going on then? On admission, the blood tests show his sodium is 136 and his potassium is 3.8. So this is quite reassuring. In a patient with renal failure, one of the key things that you need to look out for is the potassium, okay? Whether or not the potassium is normal or high. If it is high, then you need to correct it. Depending on the urgency of the situation, whether they are overloaded, acidotic, anuric, you may well need to dialyze them, okay? And if the potassium is not responding to medical treatment, make sure that you know the indications for acute hemodialysis, which if you want, I can cover for you as well in another video, all right? Let me know in the comments below. So, the urea is 18.2, the creatinine is 278 from a baseline of 87 last year, the year before. He is generally a fit and well man, looks after himself, so he doesn't really visit the doctor too much. So that's why we don't have any other blood tests during the course of this year. EGFR is 26, baseline is about 80 from last year. So things have really changed quite a lot in terms of his renal function in a fairly short space of time. So we need to find out and dig a bit deeper into what's happening here, okay? The glucose is 12.7. It's slightly high, but it's not particularly bad. He tells you that his diabetes control is actually pretty good, okay, over the last few months, last few years, and he's never had insulin at all. So let's see, on examination, this is what you find. His heart rate is 89, blood pressure is 138 over 72, perfectly reasonable. He's not hypertensive with you, okay? And his blood pressure is not low either. If it was the case that he is dehydrated and he is vomiting, having diarrhea, etc., he's hypoperfused, then his blood pressure would be low, not normal, okay? So his blood pressure is normal, so which is satisfactory. He appears slightly dehydrated, though, to you on assessment, and he's passing good amounts of urine and he's catheterized. So that's a good thing. He's catheterized, so you've got a catheter in him and you have got a clear urine output. That is important in anyone with renal failure to have a good measurement of urine output, okay? The chest is clear and there is no evidence of any peripheral edema. These last 2 points are also very important because if a patient was overloaded, then that is more of an emergency. That is, you would have more of an urgency in patients with renal failure. All right. So what do? You start him on some intravenous fluids, rightly so, because you think he's a bit dehydrated. Okay, so you start him on some intravenous fluids with the hopes that things are going to improve. Let's see what happens then. So at this point, I want you to give me a plan of what you want to do. Okay, what are the simple investigations that you want based on this information that you have so far? Okay, have a think. Here's the bell. Come back to the video in just a couple seconds. Okay, so I hope you've had a think. Here are the investigations that I think are reasonable to do. If you have got a patient with acute renal failure and you want to talk to the renal physicians, you always need to have this, a urine dipstick, okay? You always need to have this because it gives so much valuable information for diagnostic purposes and narrowing down differentials, okay? And even guiding management in some cases. Protein and blood both are present in his urine dip. Okay, so that essentially tells you that there's some kind of damage going on, some kind of leakage going on in the renal nephron and in the tubules. Okay, you then perform an ultrasound KUB, kidney ureter bladder, the urinary tract, because remember this is a fairly elderly man, 76, and then he's now got acute renal failure. So renal failure can be categorized into pre-renal, renal, or post-renal. Pre-renal is typically stuff like dehydration. Renal can be due to actual damage to the kidney itself for whatever reason. Post-renal is due to obstructive causes usually. So you want to rule out obstructive causes of renal failure, which is why you've done the ultrasound. And let's see what the ultrasound shows. The bladder is catheterized, as we know, and there is no evidence of hydronephrosis. Okay, and the prostate is normal. Okay, so these last 2 points are very important because let's say the prostate was enlarged, then you would definitely need to do something called prostate specific antigen PSA to look for evidence of prostatic cancer. Okay, even if the PSA was normal, this could be due to BPH, benign prostatic hypertrophy, and men who are elderly. This can happen. However, both the prostate and the renal system are normal, so there is no hydronephrosis. So this is not an obstructive cause of renal failure. That is very reassuring. Okay, so let's move on. What are the differentials then? We have got some more information now. Based on all of this, bring everything together. What are your differentials, doctor? Tell me, have a think, and tell me. Okay, here are the lists of differentials that I would suggest. We know that this man has got AKI, acute kidney injury, and proteinuria with hematuria. And we know he's got a background of type 2 diabetes. Okay, so taking this information into account, I would suggest that diabetic nephropathy has to be there somewhere in your list of differentials. Okay, common things are common. This is a phrase you'll hear doctors say all the time in the UK. Common things are common. You have to consider something like diabetic nephropathy. Okay, if you miss something like this out, you are going to be grilled, basically. You won't be forgiven for missing out something like diabetic nephropathy. You have to remember certain common things for each presentation. This is one of them. Other things, based on the fact that he's had proteinuria, hematuria, could be things like nephrotic syndrome and nephritic syndrome, although the blood pressure was normal, so nephritic syndrome is much less likely here. However, remember he's fairly old and he's had some B-type symptoms with constitutional symptoms of fevers, night sweats. Could it be myeloma? I think that this is very much a differential in this case. It could well be myeloma, okay? So we definitely need to investigate this. Could it be vasculitis? Maybe. We don't know just at this moment yet. This could well be vasculitis. Let's see what happens. So it's now the fourth day of admission, day four. So a few days have passed now, but the renal function has still not really improved, just barely. He is symptomatically a bit better, but still overall feeling quite drained. He's passing good amounts of urine though, so that's reassuring. That basically tells you that you've got time. Okay, this is not an emergency. That's what it tells you. You do a bit more digging deep and ask him a bit more about what's been going on, and you find out that he is denying any bony or back pains. Okay, so this is basically to do with the myeloma type symptoms. So he's denying them. So this is less likely because of that. And he's noticed a rash though over his torso and limbs areas. Now this is something. This is a positive symptom that has come up. Okay, now this should point you towards the right direction of where we are going now. And now the investigations have come back, doctor. So the investigations you ordered based on the differentials you had earlier on have now come back. Let's see what they are. HbA1c is 45. So what he told you earlier about his diabetes being well controlled is actually true because HbA1c is perfectly fine. Okay, this is satisfactory. So he doesn't need to have escalation of treatment for his diabetes. You don't really need to refer him to the endocrinologist because his HbA1c is fine. Okay, no need for insulin, nothing like that. Okay. Myeloma screen is negative as well. Okay, so this is not myeloma. We thought that maybe this was myeloma, but this isn't. Right, so anti-GBM, glomerular basement membrane antibody is also negative. What's going on then? I'm not sure. However, something else has come back. C anchor is positive, strongly positive. Right, so let's take you back to your MRCP part 1 and part 2 days. You tell me now, what is the diagnosis, doctor? If you said it is GPA or Wegener's, then you are correct. So Wegener's is the old name for GPA, which is, are you ready? Granulomatosis with polyangiitis. It always gets me. It's such a mouthful. But there you are. GPA is what I like to call it. It is now the new name for Wegener's. Okay. So this is the diagnosis. This is what we are talking about today. Let's go back to Rick and see how the symptoms fit in. Okay, so first of all, he had acute renal failure on a background of type 2 diabetes, but he's not on insulin. And we know now that his type 2 diabetes is actually very well controlled. That's not a concern, is it? On the new finding that he's got proteinuria and hematuria, as well as a rash. So in a patient with acute renal failure, hematuria, and rash, this should always make you think about a vasculitic phenomenon, okay, or an autoimmune phenomenon, something along those lines, okay. That is what you should be always thinking about. And really, there are only two main differentials in this case: GPA or good pastures. And then, of course, as he should, he proceeds to have a renal biopsy, which confirms the diagnosis. In patients with vasculitis or suspected vasculitis, they should always have a diagnostic confirmatory tissue biopsy, and commonly this is a renal biopsy done by renal physicians. Okay. In terms of complications, there are a few that you should be aware of. One of them actually presented in Rick's case as well. Okay, so common things are pulmonary involvement, infiltrates, or hemorrhage. Infiltrates are just basically, as the name suggests, infiltration into the pulmonary parenchyma, but hemorrhage can be life-threatening. They can basically ooze blood and really have large episodes of hemoptysis, which can cause their oxygen demand to go up very rapidly, and they can basically have huge amounts of bleeding, and they may well have requirements for humidified oxygen or even intubation ventilation, which is why it is important, if they have got good functional baselines and no significant comorbidities, then you should be involving intensive care in these patients. Okay, you should also be thinking about stuff like intravenous steroids if this happens. All right, but of course, supporting them physiologically with intravenous blood transfusion is key. Maintaining fluids is key. Making sure they are passing urine, making sure their blood pressure is well controlled and that it is stabilized is key for these kind of patients. Okay, so that pulmonary involvement is absolutely vital. And if a patient has got pulmonary involvement with renal failure, there are two main differentials, as I said earlier on: good pastures and GPA or weakness. All right. Another thing that you should be thinking about is upper respiratory tract involvement, very common in patients with GPA or vagus. This patient, Rick, also had this. He had sinusitis. He had recurrent sinusitis. This is one of the manifestations of GPA. Sometimes they can even have nasal septal perforation. Okay, so the middle bit can perforate because of the infiltration. Okay, this is something for you to be aware of. Acute renal injury, as we talked about, and joint involvement, it can become inflamed. I saw a patient recently with GPA who basically had an almost like a rheumatoid arthritis type picture with joint involvement. He was even stiff, but he had just that with renal failure and then subsequently found to have GPA. Okay, so joint involvement is often a finding as well as conjunctivitis. In terms of management, like all vasculitis, like all immunological issues, steroids are absolutely key in these patients, but steroids can be acute or steroids can be long term. Okay, in these kind of patients, steroids are usually long term. They span over weeks, months, years, and even lifespans. Okay, so in this sort of situation where it is long term, you have to think about two main factors. These are bone protection and gastric protection. Okay, so steroids can cause osteoporosis if used long term, and they can cause gastric inflammation, ulceration if used long term. So you need to protect them from these two issues. So you would give bisphosphonates like alendronic acid to protect them from the osteoporosis. You would give proton pump inhibitors, PPIs, like omeprazole or lansoprazole to protect them against gastric inflammation and ulceration. Okay, of course, measuring their blood glucose is also important because steroids can also raise their blood sugar and cause diabetes. Okay, the other thing that you should be thinking about is immunosuppressants, but now you are well out of your reach in terms of management. This is the realm of rheumatologists, which is why you need to be referring these patients urgently onto rheumatologists and renal physicians, particularly to manage them because they will be the ones starting them on immunosuppressant therapy, like cyclophosphamide, for instance. Okay, cyclophosphamide has got specific side effects like hemorrhagic cystitis that you should be aware of. Examiners love to quiz about stuff like hemorrhagic cystitis, okay, in patients on cyclophosphamide. So make sure you know that one. Things like rituximab. Rituximab is a fantastic drug, very expensive, works well in a lot of patients. Again, not something you will start. Often used in patients who don't respond to cyclophosphamide very well, or it is contraindicated in for whatever reason. Plasma exchange is another one that can be used in these patients. Okay, the key thing that you should be talking about, that you should be saying in your exam particularly, is that this is an MDT management, multidisciplinary team approach, okay, with multiple specialties coming together and managing the patients together, okay, and this is a lifelong process of involving physiotherapists to help with joint mobility, respiratory physicians to look after the lungs, the pulmonary infiltrates, hemorrhage if that happens, ENT team to look after the sinusitis and the septal perforations if that happens, renal team to make sure the renal function is okay, they don't go into crises, dialysis if that is needed, rheumatology to coordinate everything and also govern and dictate the immunosuppressant side of things. Okay, so these are all specialties that you should be aware of, that you should be involving and talking about in your exam. Okay, guys, so let's proceed on rapidly to the bite-sized bundle for PACES that I've put together for you. So, in terms of the demographics, these are younger patients, 35 to 55, not really the elderly. So, this case was actually based around someone I saw, which is why this was a slightly elderly patient. Also, made for an interesting discussion because myeloma was brought into the picture, because this is what happens in real life, right? Things are a bit murky in real life, they're not very clear. Okay, the history, there are a few things that you should be looking out for in the history. Things like upper respiratory tract symptoms, like sinusitis, for example, breathlessness or hemoptysis, particularly, and also hematuria. So, these symptoms, along with joint pains, will form part of the bundle that you should be asking for in the history, followed by examination. So in on the skin, you should be looking for vasculitic type rashes like purpuric small areas of rashes which are blanching, non-tender. Okay, typically over the torso, but can happen over the limbs as well. In the eyes, you should be looking out for conjunctivitis, and on the chest, if they have got decreased air entry, this may well be suggestive of pulmonary hemorrhage. But come on, if they have got hemoptysis, pulmonary hemorrhage, then you will be able to tell without even listening to the chest. They will just be spewing out blood. Anyway, moving on the chest x-ray, you will find pulmonary infiltrates and areas of hemorrhage. The hint, if you are looking for these things on the chest x-ray, not the CT, because the CT will be reported, but on the plain film, the hint that I will give you is that these changes will be bilateral, going across multiple zones of radiological pulmonary zones. Okay, if it was something local like malignancy or pneumonia, then it would be localized to uh, one side. It would be asymmetrical, and it would be localized to one zone. But in these sort of situations, because vasculitis is systemic, it will be bilateral and it will be crossing both zones, multiple zones. Okay. I hope that makes sense. So, moving on to the bloods, you will find renal failure, as we talked about, and anemia, possibly because of blood loss. C anchor is key to making diagnosis, so feel free to take a screenshot and learn from this. I hope you've learned loads, guys. If you have, then make sure you check out my book, which is currently out on my website. It is called Strategies for High Achievers for PACES, available in the paperback and also Kindle formats, and also my course. Both of them are linked in the description down below. Make sure you check it out. I'll see you in the next video.